All right, welcome back, everyone, to another edition of Dermatology Grand Rounds, Psoriasis Edition. I am joined by the vivacious and lovely Melody Young.
Okay, tell me about your psoriasis patient.
All right. I have a 52-year-old woman history of psoriasis, psoriatic arthritis, also a history of melanoma in situ on the back, has failed multiple systemics, been on every possible topical corticosteroid you can imagine. Also had been on tapinarof, didn't do a whole lot for her. She did not get folliculitis. That's usually the question. Oh, is that why it just didn't really do much. PES score 4 out of 5. So clearly her psoriatic arthritis is not under control. All that summed up into one word: help. Otherwise healthy, having been on, past biologics, she had previous lab workups before starting them, but it'd been a while, right? She hadn't had any lab workup in a while. So I'm like, all right, well, we clearly got to shift gears. Let's think about another biologic, which, I mean, you said earlier, like, we've got so many options. It's wonderful to pivot if we need to. But I liked what you said about don't just, shoot from the hip and be like, all right, you're not getting 100% clear. Let's switch your biologic. Always optimize topicals first. Switching a systemic is a lot harder than a topical. So I love that you said that. Optimize your topicals first. And then if that doesn't cut it, then think about switching the biologic. So surprise, surprise, her quantiferin gold was positive. And I kind of questioned him, like, that's kind of weird. Why would that be positive? So we did it again, and it was positive yet again. Patient was asymptomatic, and the subsequent chest x-ray was negative. However, how do we approach it? How do we think about that? So what would you do here in this setting, given that you were expecting that you were just like going through the motions and you have this now positive test?
I would proceed with having my plan for putting them on a biologic. It would not have included a TNF inhibitor. I would do, an IL-17 inhibitor because of her psoriatic arthritis. And I would have, I'm not going to treat their TB. I'm too old and lazy for that. But fortunately, have on my quick dial on my phone the infectious disease clinic in the building next door, and I would have gotten her in, got her started on therapy. Or the Dallas County Health Department is phenomenal at this. They get them in quickly, get them on therapy for free. I've done that many times, particularly clinical trial patients. While we're waiting to get the biologics approved, which takes a couple of weeks, I would have said you got to be on at least a month of TB therapy before we start. And I'll give you some topicals. Probably would have given a prescription non-steroidal pill to try to help with inflammation or discomfort, but knowing it's not going to do a thing for their psoriatic arthritis. But probably giving her some topicals. Steroids maybe because of the widespread disease and it's cheap, but also I've done prescriptions. I think tapinarof is very reasonable, and I might say use tapinarof on these areas, but let's try roflumilast on these other areas and just have her start smearing it all over. They don't want to wait after they've waited to get in to see you. And I don't mean the 45 minutes they sat out in the lobby, but waited weeks to get in, finally get in. They're ready to go. They want to get on with it. So I think, we have to have sort of an expedited therapy. Phototherapy probably would help. It's such a cumbersome, sort of helpful, but also difficult option. So there are a lot of things that we could have done with her. And depending on, even other things, methotrexate is so incredibly slow. And I don't really like to use those are immunosuppressive as well, even though it's not required for methotrexate or systemic agents.
Oh yeah, still doing it for
So
those.
no matter what it is systemically, I would be loath to do that. I'd be like, let's try. I'm not a big topical person for widespread disease. So I'd say, look, go for the places that are most problematic. Start using that right now. Probably try to get them 2 tubes at a time, dispensed at a time of whatever we were going to do, even though it's a daily application.
So, Melody, please get out of my head because I agree with all that. What did we do and what are we thinking? So, you're absolutely right. When we think about some of the more advanced therapies that we have are newer biologics, we're not so worried about IL 17s and 23s, even though, and actually, it's interesting when you look at some of the IL 23s, the important safety information has changed over the years in terms of requiring repeat TB evaluation. That's really at our discretion versus requiring it every single year. So who are we going to think about? We're going to think about immunosuppress. We're going to think about avoiding TNF inhibitors until this is adequately treated. I love how you brought up that you don't need to get through the entire treatment of the TB or latent TB, that you can start it and then integrate your biologic shortly thereafter. But yeah, you're going to phone a friend. Like, you're not going to do this on your own. So that's exactly what I did. I reached out to our ID folks. I did want to include what the current guidance is for isoniazid use. So depending on the patient, it's going to be anywhere from 6 to 9 months of monotherapy for latent TB. Active TB is a totally different ballgame. For latent TB, these are your dosing regimens. And so this is what we did with the assist from ID. It's always nice to be able to phone a friend. So we got started with that same deal. I waited about a month, then we started bimekizumab because the patient had been on other IL-17s, had done well initially, and then it recurred. So I'm like, well, what if we knock out A and F? Would that be better? As you mentioned, starting on a topical from that moment moving forward, and we will see what happened. And this was 2 months after starting bimekizumab. So I had a really nice, robust, and then durable response. This was actually from a while ago at this point, on bimekizumab, both joint and skin, because that was obviously a concern for us, and also using roflumilast as she sees fit, because she was having the same issue you mentioned kind of before of like, you have a cream for here, a cream for this area. It gets very confusing. It's nice to have a one size fits all and one that's also once a day. So she did quite well.
Very remarkable, but definitely something that we can obtain now.
Absolutely.
Inconceivable 10 years ago, 20 years ago.
Absolutely. I mean, it's so much fun being in dermatology. We have so many, just like Jack Nicholson's Joker. Look at all these wonderful toys we get to play with. But even with great toys come unique things that we have to consider. And so actually 2 weeks before that follow-up visit, I got this selfie in my in-basket, which was oral candidiasis, which we know can happen in a subset of patients on bimekizumab.
Or it can happen on, I've had it on IL-23s, definitely had it on back in the cyclosporin days. You can have it on other IL-17s. But I agree with you with my experience, and in the data it says bimekizumab has a likelihood of nearly 10%. Just over 10% of patients will have it. Yeah.
And it makes sense. So actually our understanding of the role of IL-17 in fighting candidal infections actually comes from a family that was being studied at NIH that was devoid of all IL-17. Now that's an extreme example, but it makes sense if you're knocking out 3 of the dimers, AA, AF, and FF versus just AA and F, you're going to have a higher likelihood for that infection. And this figure from a 2022 paper really highlights the importance of interleukin-17 specifically in mounting an offense against Candida. So I just want to include, what are some of the things you can do to manage this? I usually skip to the third bullet. I like giving oral fluconazole, anywhere between 1 to 200 milligrams a day for 7 to 14 days, or I'll do pulse weekly of maybe 300 milligrams, day 0, day 7. Itraconazole is out there. I don't use that as much because there's more baggage in terms of side effects, but it is an option. And with the emergence of resistant candidal species, we're going to have to be mindful of that. But the thing you really have to think about if you're going with these oral therapies is going to be drug interactions. So you have to be aware of the different CYP systems that drugs are metabolized through the liver. And certainly azo-antifungals are one of the common offenders when it comes to whether it be mostly an inhibitor, less likely an inducer. And the big one we're going to have to think about fluconazole is going to be Coumadin, which I know isn't used as much anymore given we have these advanced antiplatelet therapies, but there definitely are a subset of patients who are still on it. So the big things to really remember when it comes to antifungals, fluconazole being a strong inhibitor of CYP2C9 means that you are not going to metabolize Coumadin the right way or warfarin the right way, and that will increase serum levels, which could be dangerous. And the other one I just wanted to bring up terbinafine and beta blockers. Terbinafine inhibits a CYP system that will break down a beta blocker. And so if you have a patient with onychomycosis, bullous tinea pedis, or diffuse tinea corporis, if you put someone on terbinafine with a beta blocker, you might cause bradycardia to the point where they pass out. So something just to be aware of. So it's nice that we have EMRs that can really guide us when there could be a potential drug interaction. And more often than not, these interactions are how one drug influences the metabolism of another. Either it inhibits the metabolism, so you have too much of a good thing, or it induces the metabolism and you don't have enough. A great example in derm would be with rifampin and oral contraceptives. We use combination clindamycin, rifampin for hidradenitis suppurativa. If a patient is on an oral contraceptive, you might have yourself a rifampin baby, in that it knocks out that oral contraceptive and someone is actually able to get pregnant. So definitely you don't want to fall into that bucket. I'm sure no one is aiming for that. So with that, we're going to conclude Dermatology Grand Round, psoriasis style. Thank you so much for your case melody, for your insights, and always a pleasure to collaborate with you.
Absolutely. And I actually took a photo of your sort of algorithm, because
It's like we're at an academy meeting with everyone pulling up their
yes, because I use the chlorotrimazole troches a fair amount, because you can just sort of, and usually it will work. The thing is, it's not a recalcitrant sort of candidiasis. It's usually fairly easy to get rid of and often doesn't come back. So great algorithm, great tips and pearls on how to manage this.
Great, thank you. And thanks everyone for joining us.